Thank you, ma'am, for your detailed, elaborate comments, and thanks to Suresh sir for inviting me for the talk. I just want to confirm that my slides are visible.
Yes, sir.
Okay, thank you. So, thank you, Suresh sir. And topic that is assigned to me today is transforming healthcare research to entrepreneurship journey. And I thought I'll start with something about my own journey, then tell something about the entrepreneurs sector in India, and then tell something about what my research group has produced and what are the status of our products at current situation. So, as mentioned, I have a journey from a conventional medical background with MBBS from Madurai Medical College and Rajaji Hospital. But post MBBS, I realized that I'm more of a research and technical person, but I still do miss medicine. That's the most frequent question people ask. But then I decided to do a unique course in IIT Kharagpur called Master in Medical Science and Technology, which opened another war front for me and opened up another ocean of technology in healthcare sector. Post that, I did my doctor in philosophy from University of Oxford in medical image processing. So I'm trained in MR image processing. My passion lies in image processing as well as in assistive technologies. So today's topic I have dedicated for assistive technologies for this particular webinar. So over the various clinical and research scenario, currently I am located at IIT Delhi and AIIMS in biomedical engineering. So the topic that I will try to cover today is split in this broad category. What is robotics in rehabilitation? What is neuroplasticity? What are the technology readiness level of various products, and our journey in Center for Advanced Research and Excellence in Disability and Assistive Technology at IIT Delhi, which is a joint COE for IIT Delhi and AIIMS. So I'll start with something very basic because I realize the audience is very broad, and then we'll slowly turn into technical details. So what is stroke? Stroke is a cerebrovascular insult to the brain, which result in the deficit of blood supply, leading to non-convulsive and focal neurological deficit. So basically, when the blood supply to the brain is compromised, either because of ischemia or hemorrhage, the brain, which uses a lot of glucose and oxygen, starve for it and start showing symptoms. The commonest symptoms that are widely popularized for stroke are face drooping, arm weakness, leg weakness, speech difficulty, and that's the critical emergency. And there is a golden period in which patient can be saved to go into a permanent neurological deficit. Now, we all know that the episodes of stroke, cardiovascular disease leading to stroke is increasing in the global fact sheet as of date. And the objective of the immediate intervention if the patient reaches in the golden hour in the hospital is to prevent acute brain injury, prevent neurological deficit, and after that, even if there is a brain injury already happened, patient is moved on to a neurorehabilitation strategy to recover the potential part of the brain to do its normal functionality. Most of the time post stroke, when the patient is discharged after 3 weeks, patient require rehabilitation. And as we can see from this picture, rehabilitation consists of many physiotherapy, occupational therapy, FMG, EMG kind of therapeutic devices. And that caters almost 90 to 95% of rehabilitation regime that is available currently globally. Now, what is the role of robotics in stroke? Why I thought that we'll start assistive technology, robotics and strokes specifically. I'll tell you that. So, first of all, robotics is nothing new. There is an automated machining in industry sector which uses advanced robotics for machining and industrial environmental purposes. The robotic sector in itself is a multi-billion-dollar industry currently. And the and it is on increasing side since 1911 to 21. You can see it has become fivefold. Now, we know that there is an increase in aging population in globally. There is an increase in episode of stroke that is happening. There is an increase in episode of spinal cord injury that is happening. So robotic industry is increasing, physical disability is increasing. We thought that there is a gap that this robotic devices can be improvised specifically for healthcare in stroke rehabilitation, and that is how we thought that this is a good sector to operate upon. Now, that robotics in rehabilitation is nothing that we have thought of first time, or somebody in last decade has decided to move on. The first robotics in rehabilitation patent was filed in 1910, almost 120 years ago. It was called movement cure apparatus, and it was a very complex mechanical design where patient will lie on the bed and do a kind of cycling exercise, which would be used for rehabilitative purposes in post stroke. The next patent arrives in 1930, which was called Meridian, based on robotic devices for orthopedic therapy procedures. And it first time introduced the concept of passive devices, active assist devices, and active resistive devices. Now, this has remained a field of exploration for 50 years, but the major breakthrough in robotics and rehabilitation came in 1989 when MIT Manus was released in 1990, and it was clinically tested for plantar manipulations in 1994. And this was the device which was originally launched in 1990, which used a gaming functionality in the computer and a upper limb gripping device to do that gaming device so that the movement of the upper limb can happen. And pretty much from 1994, this device has remained in similar shape, only with better graphics. Nothing much changed, but that was the major revolution that started in robotics and rehabilitation. In 94, a Locomat device called Hokoma was introduced, which was used for rehabilitative training of the lower limb, and that is how it works. Patient is mounted on a support where patient is allowed to practice walking and to strengthen the muscles. But the idea was not that simple, that this is a device which will facilitate lower limb walking. Hokoma introduced a very interesting concept of biofeedback and introduced the concept of neuroplasticity in brain. We know that brain is the only organ which does not have the capacity to regenerate or divide if the neurons or the cells are dead, right? So there are allocated areas in brain for various movement of muscles, cognition, memory. But if part of the brain is dead, we know that it cannot regenerate. So the idea of neuroplasticity was, can the neurons which are next to the part of the brain which is compromised can take over the task, because brain has a high capacity of forming new connections with the existing neurons. It does not divide, but it can form new connections with the cells which are functional. So whether new connections can be formed which can take over the task of the compromised brain, and that was the neuroplasticity concept. So what they decided was, if the patient is walking on Hokoma and sees in virtual reality that I'm walking on a garden in a beautiful sunset scene, the brain will actually be tricked to learn the style of walking in a more coherent manner. And that was the concept we started using, and it very well merged with the development of rehabilitation strategies in last 40 years, where the therapy are decided to maximize the and maximally exploit the concept of neuroplasticity in brain. It's no more limited to doing a passive exercise by the physiotherapist, but exploit the neuroplasticity in brain to the best extent, maximize the engaging which are preserved neuronal circuits in the brain to repurpose them for the task that you want to achieve, and enables simpler and less well-organized movement of mobility to enhance activity of daily living. Everybody do understand that once the regular part of brain is compromised, you cannot get the 100% recovery. But with the simple devices, can you gain a functional recovery where patient can be mobile and independent? That was the key objectives for all the devices. So the introduction of robotics was decided because it can be an engaging environment. The intensity of the rehabilitation can be uh, tailored depending on the need. The dose of the physiotherapy, intensive task specific movements can all be customized in robotics, and robotics can work on multi-joint training with a single go. Now, these are the key features that any robotic device in rehabilitation that you envision should capture. It should be able to do a repetitive movement, task specific movement. It should be able to progressively gauge the deficit and redesign the movement. It should be goal oriented and engaging the patient to enhance the maximum capacity of neuroplasticity. Now, let me ask the audience first what they understand with the word neuroplasticity. So, as I've already explained, the neuroplasticity is the capacity of the brain to reorganize by dividing the branches of the neurons to form new connections and take over the task. Now, neuroplasticity is also not the new. The first paper which was published in neuroplasticity was in 1957. But as you see, after 2000, there is an exponential increase in the exploitation of neuroplasticity for rehabilitation. And if we put neuroplasticity and stroke, and neuroplasticity, stroke, and assistive technologies, you see we are still evolving. We get only 1600 hits when I put the search word of neuroplasticity, stroke, and assistive technologies for the stroke rehabilitation. So this is a old concept, but with the evolution of technology, it has found its new niche area. Now, this is the video which I really like to show all the audience when I tell the concept of neuroplasticity. As a trained doctor, what we learn on day one in clinical practice is what I see is I believe. So if I say that the brain has a capacity to reorganize and after therapy, the patient is able to do the movement, I claim that this is because of neuroplasticity, but I cannot see actually inside the brain what has happened. So this is one of the very beautiful experiment which I show to the audience, which actually shows the capacity of neurons in neuroplasticity. So I'm going to play this video. Please confirm you are able to hear the audio of this video.
You may think you have little in common with this robot, but it is controlled by living brain cells much like those inside your own head. Researchers grew a collection of around 300,000 rat brain cells in the lab. The cells quickly grow connections to each other and start communicating using electrical pulses. When the clump of cells was connected to electrodes, some parts of it were found to respond predictably to signals from the robot's ultrasound distance sensor. The output from these cells can be used to control the robot's motor circuits, preventing it from bumping into obstacles. Because the brain cannot leave the lab, it communicates with the robot wirelessly. The team plan to use their robot's brain power for new patterns of behavior in the future. They hope there are enough similarities to teach us about unknown aspects of our own brain activity.
So what they did was they designed a petri dish on 300,000 neurons of the rat brain was allowed to divide, and the petri dish has a lot of circuitry which was connected to IR sensor and the motor. So when the IR sensor senses that I am going to hit the distance from the wall, the opposite motor will get triggered so that the robot doesn't hit the wall. And the neuron connections was not trained, but they were learning by trial and error to form connections with the right sensor and the right motor to prevent the hit. And that was a beautiful experiment which shows how actually the neuroplasticity works. And it opened a new sector after 2000 experiment that this has a great potential in rehabilitation. Now, this is the motor cortex map and the sensory map. And we know that the brain, which is responsible for motor or execution of the muscle movement, get a lot of inputs from the sensory cortex, by seeing, by hearing, by smelling, and gauging that how much I have to do. Just a simple experiment. If all of you just close your eyes and take right hand finger, let me switch on the camera. Your eyes and take the right hand index finger away from your face and close your eyes and take the finger to your nose. Just try this experiment. So you would be able to realize that without seeing, you are able to still do this with very good precision. Now, why? Because a lot of senses which are being there, that such as the finger has proprioceptive sensors. They give you a feedback of position. It's like an accelerometer and gyroscope. So they give you the positional sense even if you are not seeing it. If you are seeing it, it's even better because the proprioceptive as well as visual feedback confirms to the brain that yes, what you are seeing and feeling is right, because there is a cross comparison, and then the motor cortex take a decision how much the movement I have to do. Now, this led to the concept of closed loop feedback mechanism in rehabilitation. So if you see in rehabilitation strategy, when patients are being asked by the physiotherapist to do the movement of the hand by using a healthy hand and hold the compromised hand in the healthy hand and do the wrist movement exercise again and again, right? So the force of the healthy hand is used to train the compromised hand, but it is a passive exercise. You can do 100 500 times in a day, but after a time there is a fatigue. Now the idea was, can the robotic device be introduced to use the capacity of brain by giving a feedback to the brain that the movement is possible if the brain thinks that movement need to be done. And if the robotic device completes the movement, the feedback will go to the brain that yes, when I thought the movement can be done, and the device completed the movement with the proprioceptive feedback, the brain gets yes, the movement was completed. Now, over a period of time, we hypothesize that this closed feedback mechanism can be strengthened, and over a period of time, the robotic device can be weaned off, and patient would be able to do the movement with the trained brain. So that's how the journey started in 2013 with my PhD student, when we conceptualized this idea. And the literature suggested there are multiple devices in rehabilitation regime, but as you can see, these are the most popular. So the common things which you can make out from this figure is all of these devices are very bulky. They are stationed at the healthcare setup in the hospital or the clinic. They use extensive mechanical joints. They are complex and requires a training to operate. And in country like India, it is very difficult for a patient who is coming with a caregiver to ask to come to the hospital every day for 1 hour to do this therapy. The compliance we expect is not good. And these are the devices which come in crores. So we hypothesize that how can we make a closed feedback loop kind of mechanism with robotics, but the device need to be compact, potentially, if possible, deployable at home, and use a simple mechanisms, but solves the problem which is very crucial for activity of daily living, right? And the joint which came out of this focus was distal upper limb joint, the wrist and the finger joint. Now, the wrist joint and the finger joint is a very, very unique joint which you use for your activity of daily living. You do this movement very repeatedly in your day-to-day activity, holding the knob, bottle, brushing. But just imagine that wrist movement, when you do a wrist flexion and then you do a wrist extension, how many times your wrist extension is associated with finger extension? Right? So most of the time you do wrist extension, it is associated with finger flexion because it is associated with grasping. Only 10% of the times the wrist extension is associated with finger extension in doing this kind of movement. Right? So, actually, brain has been trained that this interjoint coordination is very important for me to do most of the activities that I need to do with hand, right? And that is also lost when the part of the neurons in the responsible for wrist are compromised. So the idea of making a device for stroke for wrist, small, compact, with deployable settings at home potentially, you should also be having a mechanism where wrist extension should be associated and forced with finger flexion, so that the brain learns that this is a interjoint coordination I need for most of my activities. You don't want these joints to be in solidarity. Right. Now, before I take you to our jet, so I have set the problem statement so far, why we started working on the device which I'm going to talk about now. Now, there are audience which need to be informed about what is we call technology readiness level. So technology readiness level is a scale where you gauge the development of a product or a solution from TRL 0, which is the lowest, to TRL 9, which is the commercial ready solution. So TRL 0 to 1, 2 is more like an idea. You have a proof of principle that theoretically this will work for a particular problem. A schematic diagram on pencil and paper, pretty much. And then TRL3 is a proof of concept where there is an alpha prototype developed on a desktop or a tabletop model, which actually works and shows that yes, the theory can be converted into a practical device. Now, this is what an academic journey mostly ends. You develop alpha prototype, and most of the academic journey ends at TRL 3 to 4, because TRL 4 to 6 is a journey of lab validation, beta prototype, feedback studies in healthcare sector with patient, doctor, physiotherapist. So I am restricting my discussion to rehabilitative regime, but TRL status can be extrapolated to any device that you have in hand across healthcare sector or beyond. So TRL 3 to 6, 5 plus is a beta prototype model where there is a validation testing in lab in the hospital ethics institute ethic approved studies to get a feedback on what it works. Then TRL 5 plus to 7 plus is a journey of large scale clinical studies, field trials, impact studies, proving the science that the device that has been developed with a deep tech hypothetical science in the tangible product actually works and shows the clinical efficacy. TRL 8 and 9 is the regulatory compliance, scale up, manufacturing, pre-launch, commercialization, all activities, and TRL 9 is the product launch and the market sales starts. Now, if you pay attention, when I moved from TRL 1 to TRL 9, and I was showing what it includes, the distance of this x-axis was increasing, which I wanted you to pay attention that is actually the funding requirement and your product valuation. From idea to prototype to validation to clinical trials and regulatory, the funding requirement at each stage is also increasing. If the idea can be tested in a POP in few lakhs, we are talking about few CRs in the field clinical trial and almost a large amount of money in crores in when you go for a product launch, because the journey it has done is extensive. But that is the value of your startup or entrepreneurship, or your product is also high because you have done that investment and that validation process. Now, I want to keep this in your back of your mind, because now when I tell you about our journey in lab, I will refer to these TRL values for over the period of like almost 9 years that we have done. Now, this is the video of one of our patient, and I want to show you that this is the kind of stroke patient we come with. So the physiotherapist is actually asking the patient to do the wrist extension. And as you see, patient is having a flaccid wrist. Patient is not able to do the wrist extension. So whatever motivation you give to the patient, you see that patient is not able to do it because part of the brain is compromised. Now, when the part of the brain is compromised, that means the controller is compromised. The signal that need to come from brain and fire the muscle is compromised. But the wiring which carries from the brain to the muscle is there. Muscle itself is there. If magically you put a electrical signal in brain to trigger that wire, the wire will conduct the signal and put a signal on the muscle, and the muscle will move. It's only the controller which actually decides when to fire is not working, right? So that is the problem. Now that is what we need to train. So we have in the last almost 8+ years, we have done studies on 1,000+ patients to understand this problem. And just a second. So we have done almost 1,000+ patients in the past for screening to understand the problem. And we thought that a detailed understanding of how the neuroplasticity works in real patient, we decided that we'll go at 3 stages of evaluation in acquiring the data. So one is acquiring the clinical scores that include clinical physiotherapy scores of hand, which is called modified Ashworth scale, and upper limb Fugl-Meyer scale, which tells about the power and spasticity of the brain. The other is there is a signal called motor evoked potential, that when the brain fires, how is the electrical conduction of the white matter which travels to the peripheral muscle. And then a fMRI from the brain, which actually tells for a particular group of muscle which part of the brain is responsible and how it is firing. So we started acquiring all these 3 data for all our patients during our journey of the device development to see how is the neuroplasticity actually working. Now for that we had to do preliminarily a lot of studies to prove that these kind of signals are useful. There is a very bleak literature on this. So you see the MEP signal, the motor evoked potential, for a population of healthy subject with mean and 95 confidence interval is pretty much a sigmoid signal, a sinusoid signal. And when you see the MEP for patient, you see it is still a sine signal, but with low amplitude and increased in the axis of time. It is a very small signal compared to the healthy, but it has the same shape. And that is what we want to verify, that can we train the brain to have the same quality of signal after therapy. So the journey started in 2014 with all this background knowledge, and this was the first plastic sheet device with a motor on the wrist joint. And then I am going to each iteration decided based on 6 months of feedback from doctor and physiotherapist and patient to decide what we need. And this is where it landed in 2017. And as Dr. Suresh sir said in the beginning, that engineers develop a solution and then look for a problem with the doctor. Okay, where can I use it? Now, if you actually want to solve a problem, the iterative process has to be a closed loop mechanism again, where the feedback from the user, including patient, doctor, physiotherapist, or all the stakeholder, actually should be included in all the iterative cycles, because you cannot do that fundamental changes at the end stage of the developed product. It will take time, but it will give the solution which is more rugged and actually useful. So this was the final prototype we called RoboExo in 2017, where you see the student is actually using the EMG signal of the extensor compartment of the hand. So, and the device then takes over and do a movement, and I'll tell you what that movement is. And this EMG signal is being processed in a big black box that you see is biopacked. A lot of computational processing happens in the laptop, and then only the signal is generated at the motor to do this movement. Now, as we have seen in the previous video, that the kind of patient we are dealing with are having a wrist flexion. There is a wrist drop. Now, what do you mean when you have to do the wrist extension? You need the extensor muscles of the hand to be strengthened to do the lifting of the wrist and flexion of the fingers to do together, right? This activity of daily living movement. So we use the extensor digitorum communis in the wrist extensor compartment to trigger the robotic device, and then robotic device should be able to take over the movement. Now, in 2018, this is how the device finally converted into. You see that patient is actually mounting this device. He is given a Q, which is a LED signal over here. When the LED signal blinks, I'll play it again. Please see that there is a green LED signal over here. So when the patient sees this LED signal, he attempts to do this wrist extension. But the wrist will not be able to extend because the patient is having a compromised muscle strength. And after a gap of few seconds, the device will do this movement, and the movement is controlled by a single motor to make sure that the wrist is extended with a flexion of finger. And it is a very simple mechanism with a 4-bar linkage. That wrist extension is forced with a finger flexion, which is an under actuation mechanism. But the brain is being tricked that these are inter-joint coordination movements, and it has to be learned that way. So this is a controller which actually sets the parameters of individual patient. I'll tell you what are these, but the LED bulb that you saw over here in the this one, the LED light here over grid over here, that actually tells the patient how much was the muscle strength the patient has actually attempted. Now, each stroke patient is unique. The patient might be having a stroke for last 3 months, 6 months, 1 year. Patient might have received a different kind of physiotherapy, drug treatment, or some other intervention in the past. The patient might have pain in the upper limb. The angle of wrist movement that is he can do can vary from 0 to 1 degree to 5 degree to actually full range of motion, which is extension 75 degree. And you can't have a different robotic device for each patient, but a single device should be able to adapt and take all the patient needs in one in a single setting. So where this black box comes very handy. So here actually, when the patient is mounted on the device, the physiotherapist actually sets the parameter of initial angle, final angle, speed of motion, and the force required to overcome this spastic or the rigid hand. Because please note that if a large amount of force is applied, it would be very painful. The muscle can actually get tear. So everything needs to be very controlled. And with this software parameters, the motor can be controlled on when and how much movement to be given on each session. But over a period of time, these parameters are increased over a period of time slowly in confidence with the physiotherapist and the patient to maintain the comfort, but increasing the range of motion and the strength. Now, the beauty of the device doesn't end there. It is a very simple device, but the beauty lies in the black box. So there is a copyrighted algorithm in this black box that we have integrated, which actually tries to fool the brain. So brain is a very complex organ, and it believes what it sees. And you can actually try to make him learn the way you want to learn it, as long as you don't tell the brain, this is what I'm trying to teach you. Now, what happens is, when we ask the patient to do the movement and patient is unable to do the movement, the EMGs are adaptively changed over a period of time. So patient attempts to do the movement and robotic device take over. That 0 and 1 decision of taking over of the device is based on the EMG signal of the patient, individual patient. Now, when we give a cue to the patient and patient attempts to do the movement, the device will complete. But over a period of time, gauging the patient's EMG signal, there is an AI based algorithm in the device which increases the threshold, and patient doesn't know that. So every time it attempts to do, but the device doesn't take over, patient feels that I am not able to generate enough pressure or the signal in the muscle, and it attempts more harder. And that when it attempts more harder, the device will again do the movement. But this is adaptively changed without realizing of the patient that the threshold are being increased. Now, during the whole process, we don't want the patient to get demotivated. This cannot be done. So when patient attempts and it attempts to fail to cross the set threshold, the adaptively again the AI algorithm then lowers the threshold to make the patient do the movement at a lower threshold, and patient again get engaged in the process. So during the uh, whole therapeutic process of 4 weeks, this algorithm is actually playing with the brain and pushing the limits of the brain to create more and more signal to fire the muscles in the extensor compartment. Now, how that is done, to fire a large amount of electric current to reach the muscle, the brain actually recruits a lot of neurons in that particular sector, because then only the current get accumulated and the enough energy is being fired. And brain doesn't know that this is what I am being tricked into, but that is what this device does. So over a period of time, when the patient starts at 0 and leaves at 28, his neuroplasticity is completely affected, with the brain being potentially trained in this interjoint coordination of wrist and finger. And this is the device which looked in 2019, where a lot of bulk of patients to prove this closed loop feedback neuroscientific concept has been spent. And this was the device in 2020 with a remote of this black box, and the biopack computer and all processing was weaned off, and everything was done in-house in this white box in the PCB designed over here. And the US and Indian patent was approved. So from 2013 to 2020, we crossed TRL level 5 plus. Currently, we are at TRL level 7, and we are in phase 3 clinical trials right now. And this whole device, which was in 2018, was actually then moved into this small unit by 2020. And now I'll show you some results. So this was the MEP amplitude of healthy subject and patient with stroke. So we showed that there is a difference in this thing, and we want the patient threshold to come to the range of healthy subject if there is a plasticity. And this was the comparison of a control group, which is the patient of physiotherapy who received the conventional physiotherapy, whereas the patient who received our robotic intervention presented on the left side. And we see that during the pre and post therapy session, so the therapy session consists of 45 minutes of robotic intervention therapy per day, 5 days in a week for 4 weeks. So which comes to 45 minutes in 5 days for 4 weeks comes to 20 sessions, and including weekend it comes to like 28 days. So the comparison was done for baseline at 0 when we start the therapy, and post means when we complete the 28th day 20 session, how is the outcome. And as we see, there is an increase in patient active range of motion, AROM, which is like when it was 15 degree for mean 15 degree for patients, it increased to almost 34 degree, doubled. Mass is the score of spasticity, that is the rigidity in hand, and we see that the rigidity in hand has decreased significantly compared to the patient who received physiotherapy. As the device is focused on upper limb and typically wrist and hand, we see the clinical scores of wrist and hand has increased from 9.7 to 16, whereas in patients with physiotherapy it is increased from 11 to 15, and there is a significant change in the robotic group compared to the control. And when we go to the brain, which is measuring the MEP, which is the white matter signal quality reaching from brain to the periphery, we see the neuroplasticity effect has also shown. The amplitude has increased from almost 39, which is 40, to 94. And the ipsilateral RMT firing energy has reduced, so that at lower energy now brain is able to control the movement better. And the delta changes in the brain are much more significantly improved in the robotic intervention compared to the physiotherapy, which actually showed that the hypothesized device actually not only does the hand physiotherapy movement, but is actually communicating with brain, and the brain is getting trained to do movement. And this is the device right now as of today, and this is the prototype developed 4 months ago. And this is again just a single standalone device. The only wire comes to this box is a 12-volt DC adapter current, and this device has a touch screen where the angle, range of motion, speed of motion, level of threshold that need to be adaptively changed for individual patient or all fade in with patient ID. This is the EMG signal where all the processing happens in-house, and the device is called RoboExo Smart. Smart refers to sensory motor assistive rehabilitation technology, SMART, and the robotic exoskeleton, which was named earlier, is fancily called RoboExo Smart. And we are in discussions with Bio-Rad Medicines to for the commercializations and closing this process. And as we are already at TRL level 7 with this device, where the clinical effectiveness has been published, protected, and the device has reached a stage of low compact factor, we expect that with support of Bio-Rad, the regulatory compliance and the launch of the device can happen in next 1 year. But this was the journey for last 8+ to 9 years. My PhD student who completed this PhD is still working on this device to reduce the compact factor aesthetics. We took a longer time than a startup, but we are working in academic sector. And in an academic sector, the advantage that we were able to leverage to reach this stage was that we work very closely with AIIMS. The hospital, physiotherapist, doctor, patient, everybody was on board from day zero when we conceptualized the plan. So the device has integrated all the feedbacks at all steps. Second, I am a trained medical professional by my first degree and a trained biomedical engineer later. So that actually helps. And a lot of the decisions with respect to fundamental of neuroscience, patient related parameters that need to be set could be taken in-house, and a verification from doctor actually endorsed it. So that having the capacity to take most of the decision in-house expedite the process, because then we were able to reach higher TRL levels with in-house without actually involving with the industry. And our valuation for this product is actually higher as we are talking with Bio-Rad, because we are at a much more advanced TRL level than any product from any academic unit would be. Now, this is the journey of one of our device. Now, we started utilizing the capacity of neuroplasticity in a better way, and we started working on virtual reality and augmented reality technology in stroke rehabilitation. So the idea was again similar. When the brain sees some movements completed in a virtual environment and actually does that movement, the brain learns better. And how can we use that strength? So virtual reality is divided broadly into immersive and non-immersive environment. Immersive means the patient is wearing a closed goggles where the environment is visible in three-dimensional view and it's more realistic. Whereas in non-immersive environment, it's basically a computer screen or a laptop screen or some two-dimensional image to do the movement. So we also got fascinated with the immersive VR technology. It is very, very advanced in the gaming industry, but its improvisation in healthcare sector, particularly for stroke rehabilitation, is very low. So it does not require to reinvent the wheel, what is a VR environment, but improvise it for a better stroke rehabilitation. And in our first few experiments of feedback with patient, we realized that immersive environment doesn't work good with stroke patients. Now the question is why? Theoretically, it should do better because patient is able to see the environment in a very cohesive 3D view. But please also note that stroke patients are cognitively declined. Cognitively declined patient, it is very difficult for them to comprehend the complex mechanisms of this advanced technology. They get a claustrophobic effect by wearing these goggles. Their balance of hand and walking and movement was hampered because they are actually not seeing the physical environment around themselves. So the cognitively declined patient were found to be not suitable for immersive environment. So we decided that we'll work on the non-immersive environment because that make more sense for the kind of patients we are dealing with. And again, our focus was on rehabilitating the upper limb, again, wrist and finger. But now we wanted to include the index finger and opposing thumb into the movement, because once the patient has control on wrist and MCP joint, it's finger and thumb which will help to do the movement of activity daily living better. So we started with a Logitech joystick, which has advanced functionality of index and opposing thumb, and designed few maze in-house where the patient has to cognitively design the trajectory of movement, but still get a feedback at the end of this VR environment and how it is done. And again, it is EMG triggered and training the muscle. And for that, first we had to do a lot of studies on healthy subject to get into the few parameters which can be controlled. And as you see, this is one of the patient who is trying to do the movement. So you see his grip is not what you expect. He is using only the thumb's force to do the movement because the wrist is practically not able to grasp this joystick, but he is still able to manage. So over a period of time, these all quantitative feedback on the grip, force required to do the movement, opposing thumb, index finger, all that need to be get to the patient in a quantitative mechanism. And we designed all these quantitative mechanisms and did study on different patients. So here I'm going to show you a case study where a 50-year-old male patient was intervened with this robotic therapy, with this VR therapy. So he had a stroke of 13 months. It was a more than a year-old stroke. And we know that stroke recovery is very good in first 6 months, and post that the potential of recovery decreases. But with our intervention with this VR game, we see that the Fuggelmeyer score has significantly increased. The active range of motion is higher. The brain neuroplasticity again changed significantly with increase in ipsilateral MEP, and RMT decreased. And when we compared it with respect to a healthy reference, which is yellow, of 40 patients mean and standard deviation, and this is the journey of patient from day 1 to day 20, we see that the parameters that we fixed for the VR environment, which is the amount of jerky movements that it does, the amount of planning and the amount of force required, all has come in the close range to what we expect for a healthy subject. Now, it is not perfect, but over a period of 20 days, for a single patient of 13 months chronic stroke, we see that patient is able to do better when this focused therapy was given. Now, when we saw the fMRI of the patient, we also realized that between pre and post, the affected hand has cohesively concretized its neuroplastic area in a very focused environment. We saw that in pre, the affected hand has very large representation in brain, because large representation means the patient has a very jerky movements because many neurons were firing to achieve the task, but there was no control. But on the post session, the brain has narrowed down the area to a very specific neurons which are required to control the movement in a predefined manner. Now, the real surprise came when we actually saw the white matter tractography of this patient. And you see that in pre and post, the white matter tract has increased. The number of neurons that are firing and are conducting to that muscle group has increased. Now, this was a very, very astonishing result, and we did not believe it. So we gave the data to 3 different experts who do DTI analysis globally using 3 different softwares and models. And when all of them gave the same outcome, then only we actually published this result. because it was really interesting that only with 4 weeks of dedicated therapy, the white matter can be re-recruited. We knew that the gray matter or the neuron synapses can be re-recruited in a focused manner, but white matter takes months of training to recruit because this is a very slow process. And again, in an old patient of or a middle-aged patient of 50 years, but 13 months old stroke, recruitment of white matter within 1 month is a groundbreaking result. And but it turns out to be right by the three experts who analyze this data globally. And now we are doing a large study of patients on the same hypothesis. And similarly to that, a case control mechanism for 5 patients has now been published, where we see that with this focused therapy for a non-immersive based VR with the joystick, the clinical scales has significantly improved. The active range of motion has improved significantly, and we get the brain cortical representation becoming more high in amplitude at low threshold, which is kind of the mechanism we expect. And this is the device we have right now, which is a commercially available already for gaming industry, and we improvised it for rehabilitation. But the force was still not part of this device. So what we did, we changed the mechanism in this device and started introducing different kinds of springs in the Logitech this erotic training joystick, so that the different amount of now force is required to do the same movement of the wrist. And this is now the study in clinical studies right now, where chronic stroke patients are trained against resistance to do this movement without realizing that what kind of resistance they are dealing with. And this was the prototype from a non-immersive environment, from a computer screen compact to a small LED screen with the PCB board designed in-house with the game. And now we have a software which can be loaded in computer with Windows or Android in a tablet or on a mobile phone. You just plug in this joystick with a normal C port, and this can do the same kind of rehabilitation therapy which was proved on the device. Only thing is you need a good graphics, the software that we have designed, and the processing, and the joystick with the device with the force sensors that we have. We are still working on the immersive environment with the same, and probably in stroke patient who has better cognitive can be used with the immersive, but so far it is still under research, under studies. So this is our product 2, which we are probably going to launch in next 1 year. This is not our product, but I stored for a completion to show you. This is a soft robotic gloves with pneumatics, and it does a passive exercise of wrist flexion extension and finger flexion extension. Sorry, not wrist, but finger flexion extension in a passive manner. It is not controlled by a patient. There is no EMG signal, but this device gives a 6 Newton of force through pneumatic channels and helps in reducing the spasticity. Now, during the whole process, there was a very interesting feedback we received from international experts that for activity of daily living, there are home-based physiotherapy solutions for pinching, gross movements, which is called Active Research Arm Test Kit. Now, nobody in India, less than 5% of physiotherapists use this kit to assess the activity of daily living patient assessment. Now, we thought, why? Because this kit has been developed in Western world, and including the import of this kit cost around $1,150. And a European component sells the same kit at 375 pounds, which comes to almost 50 to 90,000 of rupees for a very simple kit. But it is a standardized kit. That's why it is very costly, because the measurement, the kind of movement is very precise in up to a millimeter level. But in Indian environment, it is unaffordable for mass use. So under the same project with the Center of Advanced Research in Disability and Assistive Technology, we have, with support of funding from ICMR, we have developed the same kit in less than 15,000 rupees as a sell price from our lab. So it was a very less innovation, but we realized that it became an import substitute. Within 15,000, we are getting leads from even patients that can I use this kit at my home. But as we are an academic unit, we are not the commercial people to sell, so we are tying up with another company to actually sell this kit now within like 15 to 20,000 rupees. But it was again a very simple solution for a problem which was there lying down and nobody paid attention. And this is a small video I want to show you about the whatever I have discussed so far. It was covered in DD News in 2023, and this 5 minutes video actually explains our story beautifully, and it's worth summarizing. Rather than I concluded, I thought it is easy that I show you this video.
युवा हमेशा आपको आदर्श मानते हुए आए हैं।
ब्रेन स्ट्रोक से पीड़ित लोगों को अक्सर जिंदगी भर अक्षमता के साथ जीना पड़ता है और उन्हें अपने रोजमर्रा के काम करने में काफी दिक्कतों का सामना भी करना पड़ता है। ऐसी लोगों की मदद के लिए IIT दिल्ली के शोधकर्ताओं ने क्रांतिकारी पहल की है। शोधकर्ताओं ने ऐसा डिवाइस तैयार किया है जो लकवाग्रस्त मरीजों में मांसपेशियों की अकड़न को 1 महीने में ही पूरी तरह खत्म कर सकता है।
स्ट्रोक यानी मस्तिष्क आघात देश में डिसेबिलिटी यानी अक्षमता की सबसे बड़ी वजह है। स्ट्रोक एक ऐसी स्थिति है जिसमें मरीज का मस्तिष्क सामान्य रूप से काम नहीं कर पाता और मरीज जीवन भर के लिए लकवाग्रस्त हो सकता है। इस गंभीर बीमारी से पीड़ित मरीजों के लिए IIT दिल्ली के शोधकर्ताओं ने एक ऐसा डिवाइस तैयार किया है जो महज 1 महीने में ही मांसपेशियों की अकड़न को पूरी तरह खत्म करने में सक्षम है। रोबो स्मार्ट नाम के इस डिवाइस की मदद से लकवा से पीड़ित मरीज आने वाले समय में अपने रोजमर्रा के काम खुद करने में सक्षम हो पाएंगे।
स्ट्रोक पेशेंट्स में एक बहुत कॉमन प्रेजेंटेशन होती है कि जो हाथ है वो सख्त हो जाता है, विच वी टेक्निकली कॉल्ड स्पास्टिसिटी। स्पास्टिसिटी को हटाने के लिए पेशेंट फिजियोथेरेपी करता है, जिसमें पेशेंट और उसके केयर गिवर दोनों को हॉस्पिटल जाना पड़ता है। तो स्पास्टिसिटी को रिमूव करने के लिए जो फिजियोथेरेपी प्रोसेस है वो कॉमनली 6 से 8 महीने ले लेता है। तो हमने सोचा कि टेक्नोलॉजी इस सॉल्यूशन को कैसे आसान कर सकता है। तो जो ये डिवाइस है ये कलाई पे काम करता है और जो रिजिडिटी है उसको 1 महीने में कम कर सकता है।
IIT दिल्ली के शोधकर्ताओं द्वारा विकसित ये डिवाइस पोर्टेबल, हल्का और बेहद सस्ता है। जिन देशों में प्रशिक्षित विशेषज्ञों और डॉक्टरों की कमी है वहां ये काफी उपयोगी साबित हो सकता है।
असिस्टिव डिवाइसेस की मतलब ये है कि एक हमारे पास ऐसे कुछ है जो हमारी बॉडी को असिस्ट करती है, हेल्प करती है कि वो फंक्शन हो जाए। हमने अपर लिम्ब के लिए एक असिस्टिव डिवाइस जो हमारे IIT कोलीग्स ने डेवलप किया, अंडरस्टैंडिंग कि कैसे वो डिसेबिलिटी होती है। एक स्ट्रोक विक्टिम को हाथ में जब ये पैरालिसिस हो गया उनमें क्या क्या प्रॉब्लम्स होता है वो कॉम्प्रिहेंड करते करते उसको कैसे हल करना है बिसाइड्स फिजियोथेरेपी, ये असिस्टिव डिवाइसेस उस तरफ डेवलप हो रहा था। तो एक प्रोटोटाइप हम डेवलप हुई है।
अब तक हुए क्लिनिकल ट्रायल में रोबो स्मार्ट डिवाइस हाथ की मांसपेशियों की अकड़न को खत्म करने में बेहद कारगर साबित हुआ है।
हर पेशेंट यूनिक होता है, हर पेशेंट का डिफरेंट रेंज ऑफ मोशन कंफर्टेबल होता है, डिफरेंट मसल एक्टिविटी कितनी बची है, ब्रेन से कितना कनेक्शन बचा है वो भी डिपेंड करता है कितने पेशेंट, कौन से पेशेंट में कितना हुआ, डिपेंडिंग ऑन द एक्सटेंट ऑफ द लेजन ऑफ द स्ट्रोक। कितना पेशेंट का रेंज है, शुरुआती रेंज कितना कंफर्टेबल है, बाद में जो फाइनल रेंज ऑफ मोशन है कहाँ से कहाँ तक जाएगा, कितने स्पीड में जाएगा, वो सारी चीजें इसमें हम अलग अलग पेशेंट के सिम्टम्स के हिसाब से हम इसमें सेट कर सकते हैं। पूरी कस्टमाइजेबल फिजियोथेरेपी हम इसको बना सकते हैं और पेशेंट खुद से ये ऑपरेट कर सकता है क्योंकि एक हाथ में लगता है, दूसरे हाथ से पेशेंट खुद से लगा सकता है।
इस डिवाइस को तैयार करने में IIT दिल्ली को सरकार की विभिन्न एजेंसियों का भी सहयोग मिला है।
हमें डिफरेंट गवर्नमेंट फंडिंग बॉडीज का बहुत अच्छा सपोर्ट रहा है, SCRB, DRDO, DIA, COE, ICMR। अभी हम लार्ज स्केल क्लिनिकल ट्रायल पे हैं, जिसमें हम अगले 2 साल में 200 पेशेंट्स कंप्लीट करेंगे, जिससे पूरा डाटा ज्यादा समझ में आएगा कि ओवरऑल, क्योंकि स्ट्रोक में हर पेशेंट अलग होता है, हर पेशेंट की प्रेजेंटेशन अलग होती है, हर पेशेंट की रिक्वायरमेंट अलग होती है।
रोबो एक्सो स्मार्ट डिवाइस का अब ऑस्ट्रेलिया के अस्पताल में भी अंतरराष्ट्रीय क्लिनिकल ट्रायल किया जाएगा। डिवाइस के अगले साल तक भारतीय बाजार में उपलब्ध होने की उम्मीद है। निशांत सौरभ, DD न्यूज, दिल्ली।
So, when the Australian Prime Minister visited India in March 2023, this was the device showcased to him, and then we received a letter from his office in a very personalized manner that gave us a very different platform, and we were approached by University of New South Wales and a company called Proxmed Australia in August 23, where they agreed to do the phase 3 clinical trials, what we are doing in India, in Australia as well. And with respect to that, then Biorad came into picture, and they have already signed off to commercialize this device in India, because in India we are already completed the patient requirement for phase 3 trial. And this is the robotics in rehabilitation that we expect that it will take over the position in the healthcare sector. But as an engineer, you should also see this is the reality. Our understanding of physiology, pathophysiology, clinical aspect on different advanced functionalities of brain is limited. In robotics, we claim much, but when it comes to the development for a particular task, our mechanisms are still very simple. So a journey from a reality to what we expect in future requires a lot of years of hard work, multidisciplinary team, including engineer, doctors, not as a team, but as a cohesive partners to take the decisions at one go. It's a very highly interdisciplinary research. It's not a single man's job that can be done, but a vision to deliver the solution is immensely important. Engineers or doctors tend to work in their silos to understand the problem and solution, but the kind of attitude that requires that I will deliver a solution in the end is a very different gene. It's not the publication or a patent that satisfy those kind of people. It's when a patient gives the feedback, and when one of my patient actually, so the person who developed the device is based in IIT, so those are not exposed to the patient who actually receive the therapy from the physiotherapist of the using the device, because the data has to be blinded. So the analyzer doesn't know which patient contributed what data. But on a special request, one of the patient asked that I want to meet the person who actually developed this device. And my PhD student went that day, and that lady almost cried and blessed the PhD student. The kind of work you are doing is changing a lot of life, and I give you my blessings. And the PhD student immediately came to my room from AIMS and started crying. So that is the kind of feedback which triggers the team which actually believe in delivering the solution. And so the final outcome I want you to take message is start collaborating. These are complex problems, and these require large team such as ours. We are a team of biomedical engineer, physiotherapist, neurologist like Dr. Padma Srivastava, immense clinical experience in stroke rehabilitation, with Vishnu, Professor Nand in psychiatry, who helps us understand the neuroscience of the brain, and with fMRI analysis, Professor Senthil. So it's a big team, and now we are partnering with our international collaborators in University of New South Wales. And I have to acknowledge a lot of funding support from various organizations who has helped us in last 10 years to do this journey, and our commercial partners for the devices we have developed in our lab so far. And with this, I end my presentation. So thank you very much for your patient listening. Thanks to Suresh sir for giving me this opportunity to share my thoughts. And my apologies if I have overshoot the time and if there was some glitches in the video, because the audio quality, I believe, was not good for the internet transmission. So thank you.
Audience, if you have any questions, you can unmute yourself or you can add your questions on the chat box.
Amit, good evening. This is Jayakrishan from Bangalore. It was a great presentation. Interestingly, I see that you applied co-creation from the healthcare community, so that gave you a lot of inputs, and you are able to bring out a product which really will appeal to the what you call healthcare community. But I have a couple of questions with respect to a couple of steps in the whole process. One is called design for manufacturing. That is one aspect. Second thing is failure mode effect analysis. How did you do these things? Because in your team, I didn't see people from manufacturing, any consultant or someone who have advised you on DFM. And what was your experience on applying failure mode effect analysis on such a product?
So, sir, failure mode analysis was done as part of the academic activity. So this device has 4 levels of fail-safe mechanisms. So I must also tell you that when we started designing this device, so the first question which was asked was, how much force is required for wrist extension when there is spasticity? And trust me, there was no literature on that, how much is the force requirement for spasticity of 1 to 4. Right? And so the academic exercise of data recruitment and actually measuring with a digital force sensor in-house in patient at AIIMS to measure how is the force requirement to do this wrist extension for different level of spasticity was prerequisite before designing the device. And those were offshoots of this study, which later were published and in journals and used to give input to our device. All that was done in-house. Regarding the design aspects, I agree we are not expert in design and aesthetics, but these were based on most of our help from consultants and the vendors which we were actually designing the final prototype that I showed. But all the data that I have shown you was acquired on the device which was developed in 2020, which was a scientific concept.
Yeah, the last point was, since you are now getting into collaboration with New South Wales in Australia, have you explored inter-IIT collaboration? For example, IIT Mumbai, IIT Guwahati, they have design departments, product design, industrial engineering. So to give the final, look and feel for the product, do you think that sort of collaborations also will help?
Yes, definitely. IIT Delhi also has a very strong design department. So we take inputs from our design faculty in IIT Delhi during the process. So that's what they were treated more like a consultant and gave us the feedback at different steps from IIT Delhi design department. But yes, there is a scope of further design improvisation, which I believe we would not like to enter at this stage. We want to focus more on scientific concept and developing new devices, and these aesthetic and final design changes I personally believe are part of a commercialization strategy, and I want the commercial partner to take over that task, because even if I do it and the market requirement would be dealt by the commercial partner, I personally believe that has to be done with the market hit with the commercial partner rather than an academic exercise.
Thank you, Amit. That was a wonderful presentation. Thanks.
Thank you, sir.